I'm Dr. John Bartemus, and we're going to do another case study today, and so let's dive in. Today's case study is a male that is 62 years old, and he has been struggling for years with sinusitis, prostatitis, and diverticulitis when he came in to see me. So chronic sinus issues, prostatitis, which is inflammation of the prostate, and that specific complaint had been going on for 12 years, and previous investigation had shown a lesion 4 years prior to coming to see me, and then a more up-to-date investigation showed the same lesion and it hadn't grown. So no evidence of prostate cancer, but prostatitis, inflamed prostate for some reason. And then diverticulitis is the other main complaint found on MRI when they were looking at his prostatitis. So they said severe colonic diverticulitis. Well, that diverticulitis is not that surprising given his main complaint. When he first presented, his main complaint was morning diarrhea every day with urgency. And so what is urgency? Urgency is gotta go. Okay, when you get the feeling he had to go, or else there might be an accident if he didn't get there in time. And so obviously that is an issue if you're trying to have a normal life and do things that don't require you to stay near a toilet all the time. So that was one major issue. Well, why? Okay, so when we say what were potential triggers, he says one thing that would drive it is dairy. So he would avoid dairy. Dairy would also drive his sinusitis or his sinus issues. Okay, and alcohol would too. So dairy and alcohol, either one would drive the sinus issues. And then in addition, excuse me, to dairy, gluten, veggies, and chips were reported by him to also drive bloating and other GI symptoms. So it looks like there's some kind of food reaction or some sort of gut issue where his gut and his immune system are not reacting or responding to foods appropriately. So remember out there, I've said on many videos, up to 80% of the immune system is in your gut. I also describe this in my best-selling book, The Autoimmune Answer. You can find it on Amazon. But if you've got chronic gut issues, that's chronic stimulation or irritation of your immune system, and that can drive chronic inflammation, okay? And then ultimately, intestinal permeability, hyperpermeability or leaky gut, food reactions, allergies, skin issues, mental issues, etc. So, gotta figure that out. Another thing that he mentioned was that colognes and other smells bothered him. So things like cologne and perfume and paint and other things that off-gas like carpets and new car smell. Any VOCs or volatile organic compounds caused headaches and hours of nausea for him. And again, if you're having urgent diarrhea and then you're in a place where you get triggered and you have a headache or hours of nausea, again, doesn't help you be a productive individual. And then he also mentioned that he had previously worked with a functional medicine practitioner, and he worked with them for 6 months, and at that time he had high blood sugar was their main focus. And he worked with them for 6 months, and his labs never improved. And so it's my personal opinion that you don't need 6 months of care initially, unless you're very, very complex, to get better. If you're not improving at all in 6 months, you need to change doctors or get a follow-up from the doctor you're working with, because the body wants to heal. It just needs what it needs to heal. And so if you are working with someone for 6 months and you've got no improvement, that's a red flag that you're not on the right track. Very commonly in my practice, we're seeing up to 50% improvement across multiple symptom classes by 6 weeks. So 6 months, red flag. So he was, he had worked with a functional medicine practitioner before, hadn't got results, so you could understand why he might be a little reserved in working with me. And so I explained to him, hey, we're going to be individualized and specific to you, not give you some detox that we give everybody and hope that it works for you. So what did we find when I investigated him? Let's dive into that. So since he previously had had high blood sugar, of course, we can start there because we know that was present before. When I tested his blood sugar, his hemoglobin A1C, which is the average blood sugar over the last 90 days, was lab high at 6.0%. Diabetes is diagnosed at 6.4% or more. So he clearly had prediabetes and blood sugar was still an issue for him. Now, that's half the equation. Conventional medicine often only tests half the equation and not the full equation. What would the full equation be? Well, we also want to know his insulin numbers. You can look at fasting insulin just like you can look at fasting glucose. You can look at c-peptide just like you can look at hemoglobin A1C. So whereas the A1C is the average blood sugar over the last 90 days, the c-peptide is the average insulin over the last 90 days. And his c-peptide was functionally high at 2.4. Also, his lactate dehydrogenase was lab high at 252. And his triglycerides were lab high at 195. As we've talked about before, when you're insulin resistant, that means when insulin chaperones the sugar up to the cell door and knocks, nobody's answering. So leaving sugar outside the door, the sugar wants to come inside, so it'll make a scene out in the yard. Well, your neighbors don't like that. Same idea, if you leave sugar high in the blood, your body doesn't like that because that's pro-inflammatory. And that can drive leaky gut, that can drive inflammation and oxidative stress and many other issues. So rather than leave your sugar high in the blood, the body will convert it to triglycerides and store it as fat in the liver. And that's how diabetics can develop non-alcoholic fatty liver. We don't want that, but with the lab high triglycerides and high A1C, we can see that that's happening. We can see insulin resistance and metabolic dysfunction are present, so we must correct this, okay? And in my mind, I'm thinking, we're not gonna take 6 months to do it and get no results. We're gonna get results in less than 3 months, okay? With the history of prostatitis, I wanted to run another prostate-specific antigen and a little bit more in-depth testing there, just to, again, look at the prostate again. That was all good, but we also ran a urinalysis, and in the urinalysis, he had lab high white blood cell esterase. So he had white blood cells in his urine showing, hey, the immune system is responding to something in the urine. We cultured his urine, or the lab did, and the culture was negative. So this suggests UTI, but a negative culture means there's no aerobic bacteria that would grow. Does that mean there's no bacteria there? No, it means there's no bacteria that you can grow in oxygen on a petri dish. There could be anaerobic bacteria there, and the culture can't show you that. I've made videos explaining the differences in testing previously. You can check them out on the YouTube channel. How about his gut? Well, his stool testing revealed a couple things. One, he had low elastase 1. Elastase 1 is a marker of your pancreas's ability to produce digestive enzymes. If that's low, then he may be producing suboptimal digestive enzyme levels and not digesting carbs, proteins, or fats well. How do we know? Well, the pancreas produces amylase, which digests carbs, lipase, which digests fats, and protease, which digests proteins. So if he's not doing well there, his digestion may take a hit, and if you don't digest your food well, that can be fermented by your bugs or your probiotics, and they'll make gas, bloating, diarrhea, constipation, pain out of those things. And what does he complain of? Diarrhea, bloating. So that the digestion may be relevant, whether or not he has any bad bugs there. Okay. Also worth noting, he had his gallbladder out previously before I met him. So now, if you don't have your gallbladder, you may not be producing and storing enough bile, and you need bile to digest your fats as well. And if you're maldigesting, malabsorbing fats, that could be bloating, that could be burping, that could be floating stools or tan-colored stools. Other findings in the stool test. His secretory IgA was lab high. Secretory IgA is the first line of defense in your gut of the immune system. So his gut immune system is very high. He's responding to one or more things, and that's probably behind the diarrhea and maybe some of his chemical sensitivities and maybe some of his food sensitivities. And then lastly, his calprotectin was lab high, and calprotectin is the gold standard inflammatory marker for the gut. If you read inflammatory bowel disease research, the research wants you below 50 in calprotectin. Many times I've seen it in patients' medical records where they had a calprotectin run by their gastroenterologist and it was above 50 and the gastroenterologist told them it was normal, because they don't care until it's above 200 and then they're thinking inflammatory bowel disease, maybe Crohn's, ulcerative colitis, celiac. But the research says we want to be below 50 for optimal. So he's walking around with a specifically inflamed gut, which, remember, 80% of the immune system is in there. So now maybe that's contributing to chemical sensitivities, food sensitivities, as well as the diverticulitis, sinusitis, prostatitis. Other important findings were his lipids. This guy already has metabolic dysfunction. Part of insulin resistance and metabolic dysfunction is to drive hyperlipidemia or high cholesterol levels. You've heard the story, elevated cholesterol, increased heart disease risk, heart disease #1 killer, so we want to test that, okay? Total cholesterol was high at 254. His LDL was high at 184. So any medical doctor, standard typical medical doctor, is going to see that and say, you need statin drugs, here you go. Problem with that is they're not addressing the cause. The statin drug is going to just duct tape over the check engine light, let him continue to be inflamed for whatever reasons there may be, and then he still has a heart attack later on. 40 years of statin drug use, people are dying at the same rate of heart disease and stroke, just with lower cholesterol. So that would say cholesterol is not the primary thing. How do we look more deeply? Because also 75% of people that have a heart attack have what your medical doctor would call normal cholesterol. So having high cholesterol doesn't mean you're going to have one, and having normal cholesterol doesn't mean you're not going to have one. We need a better marker, and that marker is called apolipoprotein B, or ApoB for short. American Heart Association and American Medical Association both agree in separate individual studies that this is the best lipid marker for heart disease risk. His was lab high at 159. Not good. We want to be low 80s or lower. So he's at a very high relative risk for cardiovascular disease from a cholesterol standpoint, evidenced by that marker. There's more evidence too. His PLAC was lab high at 232. This is a specific marker for vascular inflammation and increased stroke risk by up to 10 times. So again, with this constellation of things, we definitely want to see that drop. And then the last marker related here, his myeloperoxidase, was very, very high at 4,245. This is an oxidative stress and inflammation marker related to cardiovascular disease risk. Optimal, the goal is below 470. He's almost 10x too high there. So even though he's complaining of sinusitis, prostatitis, diverticulitis, clinically the most important thing in his case, in terms of life-saving and life-extending, is we have to improve his inflammation and his lipids. And to do that, we have to improve his blood sugar and his insulin sensitivity, because insulin resistance drives dyslipidemia. So again, if someone's insulin resistant or diabetic and they're on a statin but not improving their blood sugar, they're really not helping their cardiovascular risk very much. So we took action. We did things to promote optimal blood sugar sensitivity, optimal insulin sensitivity, and we leveraged natural strategies to do that. Nutrition, nutrient timing, physical activity, intensity, duration, and volume, stress reduction, toxic exposure reduction, improving sleep, supplementation. All of these things matter on some level in every case. Each patient is a puzzle, and some percentage of your 100% needs nutrition tweaking. Some percentage is exercise, some percentage is stress, some percentage is toxins, some percentage is sleep, some is supplementation. And so we dialed in his care plan, individualized and specific to him, to hit those percentages. And if you implement all of that stuff together at the same time over time, then we can retest down the road and say, hey, is it working? And when you do that successfully, it doesn't take 6 months to get no change. You can get massive change in 6 weeks or 3 months. So we got massive change with him. Let's see what happened. So on the 12-week retest, his A1C had improved to normal range at 5.5%. So this was huge for him because he had spent 6 months with a different doctor and had no improvement. So he was really impressed with that. In my mind, it's huge for him because we've eliminated the insulin resistance. And by eliminating the insulin resistance, we're drastically dropping his inflammation and changing other metabolic health factors, as you'll see. And I'll put up a pre-post table here of his blood sugar numbers and then his lipids later. But his c-peptide had improved down to 1.8. So not only does he have lower average blood sugar over time, but he's needing less insulin to get it low and keep it low. So metaphorically, if he was a type 1 diabetic, which he's not, but type 1 diabetics wear insulin pumps, and when they eat sugar, they have to give themselves so many units of insulin. Metaphorically, he's needing less units of insulin when he eats to lower his blood sugar and keep it there than he did before. So that's great. His LDH had improved to normal at 156, so an almost 100 unit drop. Big time reduction in inflammation, big time improvement in cellular efficiency and insulin sensitivity. His triglycerides were lab high at 195 before, improved to optimal at 78. So again, remember, if our blood sugar is too high, staying in the blood, body converts it to triglycerides, stores it as fat in the liver. Well, now, when you improve, you see your triglycerides go down. His had dropped over 100 points, almost 120 points. So is he more insulin sensitive? Yes. Is his blood sugar better? Yes. So big time improvement, most important clinical thing I wanted to accomplish, and we got it. We retested his PSA, prostate still good. We retested his urinalysis, and now no longer any immune activity in his urine, no evidence of UTI, doing better there. With the stool, improvement. He reported 100% improvement in GI symptoms. So no more diarrhea, no more urgent diarrhea. So he could actually leave his house and go do what he needs to do, like work or do anything fun, okay? He can eat more and different foods without bloating and getting the other GI symptoms, 100% better, okay? So we kept him off gluten and dairy because those are inflammatory, whether or not he's having the bloating and diarrhea for other reasons, okay? But otherwise, he's doing the veggies fine, he can eat chips fine, he's good to go gut-wise. And then lipids, how did he do? Cardiovascular risk, how did he do? Remember, blood sugar drove the metabolic dysfunction that were driving the lipids off. So the lipids should improve if this has improved. Well, his total cholesterol improved from 254 to 207. That's great. He's good to go. His LDL improved from 184 to 143. Again, down into normal range for his age if you're looking at research that is not there just to promote statin drugs. Okay, his apolipoprotein B, he was 159, the goal is low 80s, he improved it to 108, which is a massive improvement and massively reduced his relative risk of heart disease. So this is something we'll continue to work on moving forward, but in 3 months, that's a huge drop there and very protective. His PLAC improved to normal range at 217, so reduced vascular inflammation, reduced stroke risk, And then his myeloperoxidase, remember, was almost 10x too high. It was over 4,200. We need to be below 470 for optimal cardiovascular risk. On retest, 442. Boom. Mission accomplished. So this man who presented with sinusitis, prostatitis, diverticulitis, those were his main complaints. But underneath the hood, yes, those are important, but underneath the hood, the way that you get there is outside the gut and prostate and sinuses in his case. We improved all of those things without doing anything sinus specific or anything prostate specific. We looked under his hood and said, hey, what are the physiological priorities that really matter? And we addressed those. And by addressing those in an individualized and specific way, consistently, he became optimal, nearly optimal, and massively reduced his cardiovascular disease risk, reversed insulin resistance, so he's no longer pre-diabetic or insulin resistant, and he got those changes in less than 3 months, whereas at a different office, after 6 months, he was no better. So if you're out there and you're suffering with a chronic issue and you've seen multiple doctors and maybe even other functional medicine doctors and you haven't got the results that you desire, give it another try. Call functionalmedicinecharlotte.com. Don't call it, go to it, click on it, and call us and schedule a complimentary consultation where you and I can talk and see if we're a good fit. And if we are, we can go through your puzzle and determine your individualized and specific needs and hopefully help you reach a life at optimal.